Okay, I think we can get started with today's webinar. I'd like to welcome everyone here today to the first of a series of 2 webinars being hosted by Health Promotion Ontario with some very valuable help from Ontario Public Health Association. And today's webinar is on the topic of using technology to influence health behavior. Just brief run through of the agenda for today. We're going to start off with a bit of an overview and the introductions of our presenters and the rest of the team for the webinar. We'll then hear a presentation from Kim Hefia from Yale University Medical School on a technology called PlayForward and a particular story within that technology, Elm City Stories. We'll then hear from Bruce Baskerville from the University of Waterloo about another piece of technology being used to facilitate behavior change, Crush the Crave. We'll have a bit of a moderated discussion with the presenters to learn a little bit more about their approaches. We will then be opening up the discussion to bring some of your questions to the presenters, and finally we'll wrap up. So let's get started with a bit of a rationale for the webinar today. At Health Promotion Ontario, we wanted to host a learning event for our members in lieu of a conference this year. In truth, we really wanted to build on last year's conference theme of technology for health promotion, given the amazing feedback that we got after that conference. Earlier this year, we also polled our membership and heard overwhelming support for us planning such a learning event, including some interest both in how technology has been used to facilitate behavior change, one of the more traditional roles of health promotion, as well as for advocacy. Before I forget, let me also quickly plug next week's webinar, the second of this series of learning events, where we'll be joined by Mark Zurab from the region of Waterloo and Robin Calda from Health Nexus, who will be telling us about their work to use technological approaches to do advocacy work for health promotion. And if you're interested in registering for that, we still have a bit of space left, and you can go to the opha.on.ca website to register. And without further ado, let me introduce today's webinar and our presenters. So, behavior change has long been a focus of health promotion, though it's never been an easy task, given the need to consider multiple factors at the individual, social, and structural levels. Personally, I've learned a lot of what I know about the evidence about behavior change interventions from the field of health psychology, where I've read about how the traditional model of individual counseling has given way to a range of more modern immersive approaches, including the use of mass media, storytelling, and gameplay to engage people to change their perceptions about their health behaviors and motivate behavior change. Today we're really lucky to have 2 presenters who are developing really novel technological interventions that aim to foster behavior change in 2 very different populations. First, Dr. Kimberly Hefia will talk to us about PlayForward, Elm City Stories, which uses a role-playing game to develop social skills needed to avoid risky situations among youth. Kimberly is at the Yale University School of Medicine, where she's an associate professor of medicine, and the Yale Child Study Center, an associate research scientist in medicine, and deputy director of the Play to Prevent lab, where a lot of these interventions that she'll be talking about come from. She's currently involved in the development and testing of several health behavior change video games, and her research interests primarily focus on health promotion and behavior change through the use of video games. Next, Dr. Bruce Baskerville will tell us about Crush the Crave, a mobile app that targets young adult smokers to help them quit smoking. Bruce is a senior scientist at the Propel Centre for Population Health Impact in the Faculty of Applied Health Sciences at the University of Waterloo. He has extensive experience in program evaluation and applied health research, having been a senior manager responsible for integrated planning, performance measurement, and evaluation practice with the federal government as well. And he currently specializes in tobacco control, including the development, implementation, and evaluation of new smoking cessation interventions and innovations to existing smoking cessation interventions. And I'd also like to introduce our hosts from OPHA and Health Promotion Ontario. So Daniel Cho, the program coordinator at OPHA and the Nutrition Resource Center, is online, helping us facilitate the webinar technology. Lindsay Kawamoto, who's a health promoter and works in family health at Peel Public Health, is also online, and she's going to help facilitate the audience question-answer period. And so if you have any questions during the course of today's webinar, feel free to type it into the chat box, share it with the whole audience if you like, and Lindsay will be collecting the questions and posing them to our presenters during the audience Q&A, along with some of the questions that participants have also submitted when they registered for this webinar. And my name is Ketan Shankardas, and I'm an assistant professor in the Department of Health Sciences at Wilfrid Laurier University, and I'll be moderating the event for today. And finally, let's learn a little bit about who's in our audience today. So I see about 64 attendees online at the moment, and we have about 200 registered. And as of yesterday, in terms of the people who had registered, overwhelmingly these are people who work in public health. There are about 10 from government, and as you can see, a range of participants from a very diverse group of other sectors. The majority of us in the audience today are program staff, direct service providers. So I think that's great that we've got such an applied topic for today's webinar. We're also being joined by people who work in a more supportive administrative role, some managers, some board members, and volunteers. And without further ado, let's get started now with Kim's presentation on PlayForward Elm City Stories.
Hello, everyone. So I'm Kimberly Hefia. I'm, again, the Deputy Director of the Play to Prevent Lab. And just a quick recent update, as of yesterday, we made the announcement that we just launched our new center, a newly formed center. So we are now actually the Yale Center on our Yale Center for Health and Learning Games, which will still house the Play to Prevent Lab, but will be able to expand and do further things like bringing in students and training and kind of reaching further than what we've been able to do. So we're really excited about that. But today I want to talk to you about PlayForward Elm City Stories. It's a video game that we pretty much founded the Play to Prevent Lab with a large grant that we received from the National Institute of Child Health and Human Development. So just before I start, just need to make my conflict of interest known that I am part of NAC-Time Interactive, which is a small commercial venture which we focus on the distribution of evidence-based video games around health behavior change. And our Yale obviously manages this relationship for us. The Play to Prevent Lab, so what we do here is we develop and evaluate video games that focus primarily on health behavior and behavior change, but we also are interested in focus on social intelligence, empathy, and education related to anything STEM. We're looking at math video games right now, in fact, primarily in youth and young adults. So PlayForward, Elm City Stories. Very quickly, what PlayForward is, it's a role-playing video game. It was initially developed for the iPad, but has now been extended into Android and Mac and PC. Has an overarching story with a persistent player character that kind of continues to level up as you play through the game. Embedded in the game are 4 mini games that focus on building skills that kids need to focus or to avoid risky situations and to build refusal skills. There's about 16 hours of unique gameplay. The way that we design it for the RCT is that it can be played over about 12 sessions of gameplay. It's rooted very heavily in health behavior change theory. We wanted the idea that, for a game to be effective, that it can't just focus on teaching knowledge and having kids, learn math or learning knowledge or learning facts around sex, drugs, and alcohol. That we really needed the game to do more. We needed it to increase self-efficacy. We needed it to normalize and social norms, and we needed it to kind of shift or change attitudes around behaviors associated with risk. And then we also wanted the game to focus also on future orientation with the idea that, the things you do when you're in 7th and 8th grade can impact your future. So we wanted the kids that were playing this game to realize that some of the decisions they think may not be a big deal, when you're young, can actually impact you for the rest of your life. So here's just the interface of the game, and you can see this is the screen that the kids look at when they first log in. They start in 7th grade and they move all the way through 12th grade, kind of unlocking sequentially the stories. And within each story, there's a lot of different topics. There's anywhere from, should you let your friend cheat on your homework, to should you try grandma's pills? If you don't try them, should you try to, sell them at school? Throw a New Year's Eve party when mom's not home? Have sex without condoms? Have sex with somebody you don't know very well? There's just dozens and dozens and dozens of stories built into this game. And then as you see on the bottom, the mini games here, what happens is kids kind of go in and out of these mini games, and that's where the skill building happens. So there's a lot of exposure in the stories, but it's where these skill building games is where a lot of, I guess, like the magic is happening in terms of behavior change. Here's an example of one of the mini games. It's called No Power. And as anyone knows, that with behavior change, knowledge is an important construct. So we have a mini game that focuses on not just about, learning knowledge facts, but kind of encouraging kids to use the knowledge that they have to empower them when they're kind of getting in. And in this situation, it's kind of they're getting in an argument with friends, and they have to be very kind of witty in their comeback with the knowledge that they know. And here's another mini game. This one's called Refusal Power. This one's one of my favorite mini games. In this game, if you can see at the top, the boy here is trying to get the girl to go upstairs. He's like, "Come on, are you a tease? Why won't you come upstairs with me?" And what she has to do is refuse him. But there's a lot of backstory to it. It's not just like he's any boy that's asking her to come upstairs at this party. This is a boy she has a crush on. It's somebody, she likes. She doesn't want to be mean to him and just say no, right? She doesn't want to go upstairs because she's not ready to do that, but she doesn't want to be mean to him. So it teaches the kind of kids like how to say no and save face, kind of give them a lot of more like alternative ways to say no, like making jokes, suggesting alternatives, kind of turning the situation around on them. So they practice a lot of different ways to refuse. And then they also learn about kind of how to read what people's intentions are. So if he's like, "Hey, come on upstairs, I got something to show you," kind of understanding that probably means more than, what he's saying. He probably wants you to go upstairs so he can make out with you. So that was one of my favorite games. And then the game also embedded in the game is something called the game epilogue, and this is really exciting. This is where the future orientation really comes in. As kids play through the game, every time they make a better choice or a better decision, they can actually see how it impacts their future. So every time they log out of the game, they can go and see how it impacts their future. So the development of PlayForward, I'm just going to talk a little bit about that. We had a very knowledgeable team behind the development of this game. The formative work itself took about a year and a half. We had researchers from all different aspects. We had pediatrics, we had health psychologists, behavior change psychologists. We had pretty much a lot, just a wide variety of brains in this. We also had people from the game side, not only in serious games, but also in commercial game development, which really kind of helped really round out what we wanted this game to feel like. And then the community side, we had, it doesn't have them all here, but we had over a dozen community centers, after-school programs involved with us in the development of the game. Community engagement. This game, from the very beginning, we brought kids in to help us decide what the game would look like, what it would focus on. The stories in the games all come from the kids and their lives and things that they've told us. So we really spent a lot of time just talking with teens and learning about kind of their environment and what's going on in their world. So this game, and even the name of the game, Elm City Stories, is a play on New Haven, which is called the Elm City because of all the elm trees. So that's why we call it Elm City Stories, because it is the stories about these kids from New Haven. We had to use very creative methods to get teens to talk to us. We found out really quickly when you're making a game for 11 to 14-year-olds, trying to get 11 and 12-year-olds to talk to you about what's risky in their environment is really difficult. It's also difficult to get them to try to tell you about what their future, what they want for their future, because a lot of them really can't see past 2 or 3 years even. So we had to get really clever in the way we talk to them. So we used a lot of really interesting methods and ways to get them to talk. This one's one of my favorite ones. I had a friend of mine, he's a comic book artist, and he drew this kind of somewhat ambiguous picture of things going on at a party. And we brought this to kids and we just asked them, what's going on? And so they told us all of these stories about things that were going on at this party, and which naturally led to things that happened in their own lives and things that they had seen and knew about. If you look, like on the right, these boys here, the that are pointing, according to the kids, they're watching a fight, or they're watching or they're gambling. The guy on the left, he's calling his drug dealer, or he's calling his boys to come over and beat up the boys on the right. And the girl in the very center that's looking at her watch, interestingly enough, every focus group said she was pregnant, which led, of course, to my mom had me when I was 14. Yeah, my sister had a baby when she was 16, on and on. So we really learned very quickly that a game about HIV, STI prevention needed to focus on more than just HIV and STIs. HIV, STIs, and reality for young kids, that's not what messes up your life. It's being pregnant and having to drop out of school. So we made the game more focused on things that was really important to them, as opposed to what we thought, the game should include. Part of the development, the formative work here, was to create a conceptual model of the game. So we actually broke down every single component and aspect of the game, and we're able to kind of connect it to exactly what we wanted it to do and what it would influence. So you can see how each of the mini games are broken down on the left to what we wanted them to specifically do in terms of improve self-efficacy or increase knowledge or change attitudes, and then how those would lead to behaviors and how those would ultimately lead to our goal of reducing HIV infection. Everything we did, we put on paper first. So before the actual coding of the game ever happened, we created something we called them game playbooks, which were behavior change manuals for every aspect of the game. This is what brought in the theory, brought in the game design, literature, everything and anything that you can think of, we put it all in writing first, and had everything fleshed out before we ever went into coding. This is huge, and this was a huge undertaking, but it's so important. It'll save a lot of time and money later when you have to actually go into development, if you have everything on paper first. And this was also good for us too, because this was what we used to communicate with our game design folks with. So we were all on the same page. We knew exactly what we wanted the refusal power mini game to do, and we could kind of use that as a guide, so there was never a question of what that part of the game was supposed to do. Again, like I can't emphasize enough the importance of having the kids involved in developing this game. We took any artwork, any part of the game, playtesting, we kept continuously taking it back to the focus groups, and kids will tell you how it is. So, you know, they tell us, oh, we like him, nobody wears pants like that, you know, that girl looks like an alien, that guy's way too old, you know, our schoolroom doesn't look like that, you need a trash can by the desk, you need a clock above the door. You know, they really told us how it was, and we took that to heart, and we made all the adjustments according to what they said. Another thing that we did that we thought was really a great idea I wanted to share was that we really wanted this game to be authentic and true to the at-risk minority youth here in New Haven that would be playing our game. So we sent cameras out with them and asked them to just take pictures of anything and everything in their environment. And then the game design team actually translated that directly into the game. So this was really exciting. And as you can see here, here's an example of how a highly iterative process this was. This is just one tiny mini game, a small mini game, and how many different iterations that went through before we got it exactly where we wanted it. Right now we are in the throes of a randomized controlled trial for PlayForward. We just finished up with our 12-month data, and we're finalizing collecting our 24-month data. Obviously, especially for those that work with and understand health behavior, that behavior doesn't happen immediately, and sustained behavior is really what we want to see. So we're actually following 333 kids over 24 months to see if the kids that were assigned to play our game, if they were able to make better choices related to sex, drugs, and alcohol, as opposed to those that were assigned to play the control games. I don't have the data yet on that to report, unfortunately, today. We are working on analyzing our 12-month data and we should be releasing that within the next month. I can tell you quickly, though, that we did do some preliminary research or reports on some of the preliminary findings related to the knowledge and knowledge acquisition in the game. And I will just move here because I'm running out of time. Our in-game data, we were able to show that the data that we were able to collect in the games, so the things that kids did in the game, we could actually translate that to their responses on the assessment data that they did in real life, the standardized assessments, which was really exciting because what we found, sorry, I'm rushing through because I've run out of time, but what we found is that the kids that completed more levels actually had a higher knowledge score. So this is really exciting, especially in terms of intervention. So it's not necessarily how much time that they were exposed to the intervention, it was actually how far they got in the game and how many levels they were able to complete. That was what was significantly contributing to their knowledge score and the standardized assessment outside of the game. So that was really exciting to us. So just very quickly to wrap this up, our formative game was essential to our game development. Our literature, conceptual model, and behavior change manuals really guided the development, chose what we, shaped our game and chose what we needed to use to assess. In-game data, I didn't get to really talk a lot about that, but it's something that we're really exploratory and excited to see, and we're really exploring that with this game. We do know, and we are showing that PlayForward does increase HIV risk knowledge, and that exposure to game components is definitely correlated with increased knowledge on standardized assessments outside of the game. So thank you very much for your time. Sorry I went a little bit over there.
Thank you so much, Kim. That was really interesting. Our next speaker, and so we'll hold questions until we've heard from Bruce as well. But just a reminder to the audience that any questions that you have for our presenters, you can type into the chat box in the lower right or on the right side of your GoToMeeting screen, and Lindsay will be collecting those questions to pose to the presenters. And so now let's introduce Bruce and have him talk to us about Crush the Crave.
Thanks very much, Katan. Hello, everyone. I'm going to give you a brief description of an evidence-informed smartphone smoking cessation app that our team here at Propel has developed. And some of our team members are listed here on this first slide. They include a very health psychologist you may be aware of named David Hammond. We have social media and technology experts such as Cam Norman. And Robin Whitaker from New Zealand is also part of our team, and she's been working in the area of mHealth for the last almost 10 years. So we're going to give an overview of the development of the smartphone app that took over the last few years, as well as some very preliminary findings on the results of our randomized controlled trial. I have nothing to declare other than this research was funded by Health Canada under the Federal Tobacco Control Strategy. And we also have a Canadian Institutes of Health Research grant to help us carry out the randomized controlled trial. So why an app to help young adults quit smoking? I think you're all aware that the largest percentage of smokers in Canada are young adults between 19 and 29 years of age, with a prevalence of 22%. And the transition between high school and young adulthood is a difficult time period, lots of health behaviors such as smoking get picked up. We know that in high school, smoking prevalence is about 6%, but when you get into the beyond 20, we're getting as high as 22% in certain provinces. So it's an important problem that needs to be addressed, and getting a deeper understanding of those transition years is very important. We also know that smoking is the biggest cause of mortality still, 30% of all cancer deaths, and more than 85% of lung cancer deaths. And we know that if you can get some people to stop before they reach 30, they have the same outcomes as someone who's never smoked, according to Richard Dahl's research from several decades ago. We also know from the Canadian Wireless Telecommunications surveys that almost all of them have a mobile phone, and about 70% of them own smartphones. So the digital divide is closing. More and more young adults are getting access to smartphones, or choosing that technology over other technologies. We also know that there's a lot of apps on the market, thousands and thousands of them, just for smoking cessation alone. But we also know that much of that is not evidence-informed or has been developed using principles of behavior change. So starting in January 2012, we got about trying to develop a smartphone app to help young people quit smoking. So social media and mHealth, it's a new area of research for us, and we see it as a great platform for assessing reach into the community, and as well as having an impact on smoking. From a population health perspective, impact happens when large numbers of individuals can be reached with effective interventions. So that's why we see this platform is so important for us. We also know that there's been a number of systematic reviews that have been done to date, and we've seen that mobile text messaging is effective, but we haven't got enough evidence built yet for mHealth apps to demonstrate the same effectiveness for smoking cessation. So this research is contributing to that. And so for the objectives for this afternoon, as I said earlier, just want to describe briefly the process that we use to develop Crush the Crave and share with you some of our preliminary findings. So it was an iterative process that we engaged in terms of development. And our objectives were, of course, to build an evidence-informed quit smoking app, as well as test its usability, design, and functionality. And I'll talk about the methods that we used momentarily. Our target population, as you can imagine, is young adult smokers, 19 to 29 years of age, and we've targeted both English and French. So the app was developed in both of Canada's official languages. These are the methods that we employed. We carried out what we call a comparative analysis, looking at other apps that are available on the market, see what the most common features were and what was missing in terms of evidence-based guidelines. And the guidelines that we chose to use were the U.S. Preventive Clinical Practice Guidelines, which go into detail about how to prevent tobacco use. From this, we conducted a brainstorming exercise with our knowledge partners at Leave the Pack Behind, which is a program that runs in colleges and universities in Ontario, now across Canada, to help young people quit smoking. And we worked with our computer science team here at the University of Waterloo to create the blueprint for the app, the actual concept for the app. We then went about doing a first round of focus groups with young adult smokers. That happened in Waterloo. We had 2 groups of males and 2 groups of females. And here we sought their ideas in terms of what the app should be and what was being proposed, what features. And we wanted to get their perspective or likes and dislikes around the concept, the blueprint for the app. We also brought together a panel of experts, our expert advisory group, and included people like Peter Selby from Toronto, who's a tobacco control specialist, Paul McDonald, who's a health psychologist. We had Cam Norman as well, who's now part of our team, who's a social media and mHealth expert. We brought them together along with people from the Canadian Cancer Society to talk about what the app should do. We then launched a second round of focus groups, taking all that information we gathered into consideration, and those groups happened in Ottawa. We had 4 groups in French and 4 groups in English. These groups actually tested the app that we had developed at this point, the first version of the app, using actual smartphones. We had those focus group sessions were held, and they used the smartphones themselves, and they were pointing out to us again what worked and what didn't, and they offered a number of suggestions for improvement. We gather all that data up in those focus group sessions and conduct a thematic analysis, more of a narrative summary, to try and capture the essence of the focus group discussions that covered the features, design, and functionality of the app. We also beta tested the app live using a Think Aloud protocol and videotaped actually 5 smokers who were using the app and interacted with the app. That was the final stage of our development effort, and all that information was used to create the final version of the app, bringing it back to our computer programming team. So here are the results. The comparative analysis and the expert panel are here first. From the comparative analysis, we saw that Crush the Crave was assessed positively as having met 20 out of 23 of the U.S. Public Service Clinical Practice Guidelines for treating tobacco use. This was an assessment survey that Linda Abrams had developed for assessing tobacco use interventions. And our expert panel also in general felt that the app was very comprehensive and worthwhile, and suggested that the app include info about community services and links to a community of people trying to quit, such as the Facebook community. I haven't got time to share with you the concept development focus groups, but we do have results from our technical focus group session. This was the second round of focus groups that provided feedback on the first version of the app. There were 2 broad thematic categories that emerged from the review of the focus group transcripts, design and functionality. There was also a third category that we labeled as additional insights. So in terms of design, participants found the app easy to use and navigate, and there were 2 sub-themes that emerged concerning the importance of tailoring, with such comments as the more options you can give the person who's trying to quit, the better, whether they want to quit by themselves or quit today or quit 2 weeks from now or even a year from now, they should have that choice. And it is true that in the research literature on tobacco control, it's quit attempts that are important. The more times you attempt to quit, the better off you're going to be in the end. Also comments like it knows how old you are, it knows how much you smoke, it knows what you want to keep track of, why you don't, etc. That person really liked that. So there are a few questions that the app asks the user before they engage with it that allows the app to tailor to them specifically. Also comments about coming from a credible source. One comment saying being connected to a credible organization would probably make that one stand out a little bit. So when people are perusing the Android Play Store or whatever looking for apps, if they do identify it as coming from a credible source, they may be more inclined to use that app. So it's important that we put as much into them as we can to make them effective. The focus groups also regarding functionality, that was also viewed favorably in terms of the calculators, inspirational messages, etc. They like the tracking of smokes and cravings, the awards, the quit help information, and the social networking opportunities that are built into the app. So for example, a quote from social support and social media, I like that idea. I'm not one to have everything on Facebook, but if it was something that I was proud of myself for, which would be quitting smoking, yeah, I'd like everyone to acknowledge that. And they also commented on the importance of things like distractions. It goes directly to the games that are on my telephone. I can go on Facebook or Twitter with it. When I'm on Facebook or Twitter, you think about something else, referring to smoking. And I think it's a super good idea. So those are some of the comments that we received. And of course, the app also tracks more than just monetary gains, but also health gains. So that's built into the app, and one individual thought that was important as well. We also had some additional insights. Journaling the quitting experience is part of what's built into the app, and that's done through a sort of a little mini diary of where they're smoking, who they're smoking with, and when they're smoking, as well as through a geotagging feature that lets them quickly identify where they've had a cigarette geographically. And the comments regarding that were positive. For example, a lot of people don't understand why they smoke and in what situations, and in the other screen it tells you how you feel, and perhaps you don't need to hang out with friends. So they see, based on the feedback they're getting, where their trigger points might be, and that's important. We also learned that despite the fact that quit line access and other community resources were provided over the app, some individuals did not think they'd make use of those services. For example, I don't know too many people that would call that number, referring to the quit line number that was built into the app. There's also concerns about confidentiality and the use of personal information. Comments like, personally, I wouldn't use the app if I thought somebody was using the information. So people are very cognizant and wary of what happens with the data that they're providing. So what we have here is this diagram is summarizing all that development work for the app, and it's using the principles of persuasive technology. We know that smartphone apps, websites are considered a form of persuasive technology that are interactive and designed to change user attitudes and behavior. Bill Fogg from the University of California and others have developed these design principles for software that enhance persuasiveness based on the evidence for behavior change, drawing on multiple theories like social learning theory and multiple studies that have shown what works. We have seen recently systematic reviews that have been done that demonstrate that adherence to an intervention is key if you want to have success, and studies have shown that 55% of the variance in adherence is explained by principles of persuasive technology. So this diagram is depicting how we've adapted the behavior change design principles with regards to persuasive technology for Crush the Crave. So in addition to being a credible resource coming from the University of Waterloo, the app has what we call dialogue support, with such things as messaging tailored to the user and push notifications to remind them to use the app and when they've achieved a certain milestone. There's task support with such things as a customized quit plan and provision of feedback on progress attaining goals through the tracking of their awards, for example, that they've achieved, and social support, such as the connection to social networks like Crush the Crave, Facebook community that's built right within the app, and sharing successes with their own network of friends. There's quite a lot in the app, and it's hard to cover it all in the time that we have. But just to reinforce that implementation considerations are really important. So thinking about context, mechanisms, and outcomes and how all that works is really applicable to app development as well. Here are a few of the screenshots taken from the app, and it's based upon these design principles of persuasive technology and what we've learned through the development effort. The first shot is the home page, and the app has the ability to have some personalization. So in addition to the small number of questions that users are asked so that the app can be tailored to them, it also lets them create their own affirmation that comes up on the home page, as well as pick photos that are personal to them that might be motivating for them to help quit smoking. And the app just works by clicking the buttons Crave or Smoke, and everything else is invoked after that. So our research has showed us that dealing with cravings is key, since they are the major contributor to quit attempt failure. And a deeper understanding in terms of smoking cessation is developing, where the more quit attempts that we can get people to engage in, the better off people are going to be in terms of success. So it took us about a year to get the final version of the app out there for people to use. And it was done, as I said earlier, with the input of young adult smokers all the way. Even the name of the app was chosen by young adult smokers. They were in a focus group session. We laid out a number of different names and asked for ideas, and they basically voted for the name Crush the Crave. So here's some additional screens here. We see the smoking text message that comes up with an image and a tailored message to where they're at. There's the Quit Help page that talks about quit aids and how to deal with cravings, etc., connecting to the quit line, and they can revisit their quit plan if they want and actually link up with other online resources that we've determined as evidence-based. There's advice on how to use the app. There's progress charting. There's a page of your triggers, etc., and all the different health calculators and monetary calculators that can be seen with the app. So now turning to the randomized control trial. So after doing our development work and piloting the app, we actually had it running before we launched it across the Android Play Store and iTunes with about 300 people, just to get further understanding of how it worked. And then after that, we received the CHR peer-reviewed funded grant in 2013 to conduct this pragmatic randomized controlled trial. And I'm using the word pragmatic because it's happening in the real world. We're recruiting people in real time and assigning them to 2 different conditions. The intervention arm is, of course, the app, Crush the Crave, and the control arm is the paper-based self-help guide On the Road to Quitting, which is a well-developed self-help guide promoted by Health Canada, and we felt that was a fair control condition. We didn't want to have a control condition where the individuals were getting nothing. We didn't feel that was right for people trying to quit smoking to give them nothing. And given that we're trying to test the efficacy of technologies compared to other self-help tools, such as paper-based guides, we felt that was the way to go. So our primary aim is to reduce smoking prevalence as measured by self-reported 7-day and 30-day point prevalence abstinence, which is not having smoked a cigarette, even a puff, in the last 30 days. And we have a number of secondary aims, including examining outcome measures of cessation behavior, such as the number of quit attempts, nicotine withdrawal or craving, reduction in cigarettes, and examining satisfaction and patterns of app use, including the extent to which it promotes use of established smoking cessation services, such as NRT or maybe consulting with health professionals, etc. Those results, in terms of the protocol, has been published, and we're just in the phase of submitting our paper on the development of Crush the Crave. That should be out momentarily as well. So methods for the RCT, we had a multi-pronged approach to recruitment. It involved Google and Facebook ads. We had online classified ads, and we actually worked with our partners who serve young adult smokers to help distribute recruitment pages to them. There was calls to action that went out on the ads, and we offered incentives for participation of about $35, and also the opportunity to be entered into a draw at the end of the study to win an iPad Air. So we have 3 points of measurement. There's the baseline questionnaire, contains your typical demographic questions and questions related to the aims of the study, including a number of questions on the knowledge about quitting smoking and psychosocial questions regarding their perceived stress and social support and self-efficacy, etc. We also ask questions about other cessation aids that they're using, etc. The follow-up questionnaire is shorter. It only asks questions about smoking and use of the interventions in terms of are they actually doing what we had thought they'd be doing with the intervention. And then finally, we have our follow-up questionnaire at 6 months, which asks all the detailed questions from baseline, as well as questions dealing with the level of support they may have received from friends and family for quitting, overall satisfaction with either of the interventions. And we actually followed a modified Dillon method for reaching these people, and we tried to contact them at least 10 times, either through email and telephone, to reach them to fill out the final surveys. There's also a lot of process or implementation tracking that's going on in the background with regards to the app. We're looking at how many times people log in and use the app, the number of user clicks on the smoke and crave buttons, the extent to which they achieve their milestones, etc. We do that through our own system, and we also work with the Google Analytics metrics that comes off Google Analytics, which includes the aggregate number of visits, page view counts, and average time spent on a given page within the app. So to obtain a more in-depth understanding of these any potential barriers or facilitators to uptake of the smartphone intervention, we're also conducting interviews with volunteer participants, and those findings are just being that data is just being gathered up now and should be readily available. This is just one example of how we're tracking implementation. This is just a graph of all user logins and all new accounts by day through the period of August until November 2014. So it shows a fair amount of activity, and actually it was rising at a certain point when we got to the fall in terms of people actually logging in and creating accounts. Other data that we've got, and this is very recent as of November the 27th, right now we have over 4,000, says users here, it's actually installations. So there's over 4,000 active installations, and the breakdown between Google Play and Apple iTunes is there as well. And of course, we've been targeting 20 to 29-year-olds, and that's where the majority of our user population is coming from. And we also have the gender breakdown here as well, about 57% female and 43% male. Now, we're turning to the preliminary results, and this is very preliminary. You're the first group who's had a chance to see these results because we just closed the completion of the follow-up survey yesterday on November the 30th. That was the deadline for completing all follow-up surveys, and that was achieved, and so we're now in the phase of starting to analyze the data. So we had over 3,700 survey starts, but of course you had to be eligible for the study. And eligibility included obviously being 19 to 29 years of age, you had to be a daily smoker, you had to have intentions to quit in the next 30 days, and of course own a smartphone. And you could not have been referred by another study participant to be part of our study, to avoid cross-contamination. So we had about 1,900 people who were then deemed eligible, and then from there, 1,600 actually completed the baseline survey. And we work our way down, we can see that at 6 months we have about 55% completing from those who actually completed intake. So that's how the study has flowed. So we feel that a 55% response rate is pretty good, given that this is mostly an online-based survey with people using the app all across Canada. So here are the participant characteristics for both the intervention and control arms, so the Crush the Crave and Leave the Pack Behind. So we have an average age of about 24, 53% male, 48.5% have less than 30K household income. Majority of our user population is white, but we're also very interested to see that 12% identify as Aboriginal. Again, we have the majority coming from Ontario. Unfortunately, our study was not conducted in French. We didn't have any French questionnaires or anything, so we have a very low turnout from the Quebec population. And we see that these people are very addicted, being young people. 70% have their first cigarette of the day in under 30 minutes. And we also did a quick analysis yesterday to look at whether the two groups were different, i.e. the intervention group or the control condition on these characteristics, and they did not differ on any of these characteristics. So the two groups are very well matched. So in our case, randomization seems to have worked. Now, again, very preliminary findings. You're the first group to see these findings, and what we're showing you here is just the primary and secondary outcomes of our trial. And we can see that for the self-help paper-based condition on the road to quitting, we've got about 28% indicating that they were smoke-free at 30 days versus Crush the Crave at 25%. We don't see any significant differences here across a number of these indicators, except for cigarettes per day, where the self-help paper-based condition looks to be lower at 7 as compared to the Crush the Crave, which is averaging around 8.7. It is statistically significant at the 0.05 level. We have to ask ourselves whether that is a substantive difference, if it really makes a big difference. But we can see on all these other indicators we've collected so far that there isn't any significant difference between either of those groups. And the quit rates are significant overall when you look at it from a population health perspective. So just to wrap up, our team is very excited about this research, and it's one of the only 3 studies that we know so far to assess the effect of a smartphone app on smoking cessation, and to our knowledge is the first large sample size study of young adults. And so far, we see that a well-developed app has the same effectiveness as a well-developed paper-based guide for young adults. So at least the app is not causing any harm or is less effective than a self-help guide. So that means that young adults and other smokers have a choice. They can use paper-based self-help materials if they want, or they can use a smartphone app. That's how we're interpreting the data so far. The study also has an important implementation research component, as I was describing earlier. We don't know yet enough about usage of the app and what effects occur if you go through all phases of the app and you use it more often than others. We're going to be studying those questions momentarily, and it should provide us insights into why the app works and for whom and why it doesn't work, etc. This research, in our opinion, has potential for informing decision-making by health practitioners and policymakers in terms of adoption of mHealth for smoking cessation. And the findings are going to be critical as more and more decision makers are being pushed toward adopting and scaling up mHealth solutions. And this is often happening in an environment without any evidence. There's just a big push from industry to adopt this technology without evidence-based science behind it to support it. So I just want to send a big thank you out to the people who contributed to helping us develop Crush the Crave, notably Leave the Pack Behind for their expertise. I want to thank our team here at Propel. A number of staff and other investigators have been involved in helping to create Crush the Crave and make it a success. And again, a final thank you to Health Canada and the Federal Tobacco Control Strategy. Thank you very much.
Great, thank you, Bruce. And thank you to Kim as well. Those are two very interesting, unique approaches to using technology to help foster behavior change for health promotion. Just a reminder of where we are on the agenda. We're now going to have a bit of a moderated discussion. I've been compiling a range of questions that I have for both presenters. And another reminder that if you have any outstanding questions, please do type them into the chat box on the right side of the page, and we will be posing those questions as well momentarily. So I'm going to start with a question for both of you. It's really exciting what's happening, and I guess, Bruce, in your case, the app is now sort of out there. It's available for widespread implementation or uptake. It's out there in the Play Store and on iTunes?
Yes, it is, yeah.
And so, Kim, what about Elm City Stories? Is that available yet, or is it something that you have plans for in the near future, or is this something that you imagine being used in a more facilitated way with groups of children?
Well, so a few different responses for that. Since we are still in the throes of the randomized controlled trial, we still haven't released the game publicly. And second, we're actually trying to collect a lot of data on implementation around, what's the best way to get this game out there in terms of classrooms, especially in the U.S. where, sex ed is kind of tricky to kind of maneuver. So we haven't put it out yet, but we do have it available for individuals that are interested in, doing pilot research with us and kind of looking at implementation. We've partnered with a group here in the U.S., Peer Health Exchange, and we're implementing our game as a part of their curriculum in San Francisco, Chicago, and Boston, and we'll be collecting data around that. As opposed to with your question around iTunes and Apple, we may have a very difficult time actually getting the game accepted through iTunes because of the content. So we're just really kind of looking at what the best approach is to getting this game to the kids that can benefit the most.
Okay, and I'm going to build off of that response in a second. I quickly want to ask, you did mention that the game is available for sort of groups who want to pilot it. If anyone in our audience wants to pilot it up here in Canada, are they able to sort of get in touch with you and request that?
Yeah, I mean, absolutely. One of our partners here at the lab is assistant professor at McGill. So okay. We are partnered, with her and what we're doing there. So yes, absolutely.
Okay, and you did mention that one of the issues you perceive with getting it on iTunes is the content and as well more widely in classrooms. And here in Ontario, we're actually experiencing a very similar kind of dynamic as we try to introduce a new curriculum on sex education to students in primary school. And there's been a lot of protests from community members. So I was going to ask you about whether you anticipate or have experienced pushback from parents or others in the community about the content. And it sounds like you're sort of anticipating that. Have you actually experienced any complaints or anything like that?
You know, actually, no, we haven't. It's been really quite exciting. And what we did to kind of maneuver around the schools was that we were for the most part in after-school programs, which are often not run by the schools themselves. They're at the schools, but not run by the schools, so that they partnered with other organizations. And they were happy to have us, and they were excited to have us. I can't even, out of the 333 kids, I can't even say that we had any parent, you know, pull their kid out or was like, no, I'm not okay with this, or anything. I think we were very well received, and I think it was also kind of seen as a very needed, something that's kind of very needed, especially the school systems here in New Haven don't require sex ed. So, you know, we were very welcomed.
Okay, great. Bruce, so your intervention is really targeting smoking cessation, and of course there's a long-standing social gradient in smoking prevalence. So the less wealthy are the ones who are carrying that burden, and they also carry this economic, a lack of economic resources that makes accessing data plans a bit of a burden for them as well. How have you figured out how to make sure this app is going to have an impact among the population with the biggest burden of smoking prevalence?
That's a very good question, Ketan, and we've been aware of that. I just came in from a series of focus groups that happened in Toronto last week, and economic disparity is a big factor, and individuals are making choices. One of the things, though, that we picked up on when we were having discussions with these individuals, and these are young people who were unemployed. Many of them were living in situations in terms of home that wasn't secure. They were either couch surfing, or they were homeless. But they had actually opted to pay the money to have a smartphone. Now, the issue with regards to the data plans is a problem because it's going to consume their resources. The way that Crush the Crave works is that you don't have to have a data plan to make it operate. You can connect wirelessly through free wireless services, which are available in many urban centers across Canada. And we've recently done some work because we've received this feedback from others who've been using Crush the Crave. We've now come up with a very draft version of a totally native app, a version of Crush the Crave that is totally native, that doesn't have to be connected wirelessly at all. So if people have an iPad or a smartphone, they can run the app without having to worry about any data usage at all. So we're working on that. We hope to get that out in the next version for people to use. There is still a bit of a digital divide, but over the last several years, it's starting to close. And when we speak to young people, many of them make a choice about what they're going to spend their money on, and they'll choose a smartphone over everything else. So they won't have any other technology, but they'll have their smartphone. And we're seeing that happening more and more. It's not going to close the gap completely for everybody, but as the technology gets cheaper and cheaper, as there becomes cheaper and cheaper forms of smartphones available, it'll close even further. So yeah, we have had that feedback, and at the same time, we're seeing people who seem to be living in lower economic situations who are still making use of smartphone technology.
That's great to hear. I think the native app idea is a fantastic one, but it's also encouraging to hear that the digital divide is closing a bit. I actually am involved in a project that uses Twitter to collect data, and it's meant to be an intervention to address health inequities. But you know, there's always been this elephant in the room that the people that we're trying to collect data from and in turn provide resources for are not going to be the ones necessarily interfacing. But I've always imagined that, well, this might be something that we're developing for a time down the road when that digital divide has closed. And so it's encouraging to hear that that's sort of what's hopefully where we're moving toward. Kim, PlayForward is clearly embedded in using storytelling as an intervention. I can't quite imagine that before there was any sort of a digital way to immerse children in storytelling that this kind of a health promotion intervention would have been possible. Although I kind of wonder, were there board games before we had smartphones that were geared towards health promotion? Maybe before smartphones, were there more sort of desktop computer-oriented games that were trying to do behavior change and health promotion? Or is this really a development that has emerged much more recently, maybe as we've gotten used to being around digital storytelling? So maybe if you could just give us a sense of the history of using storytelling for behavior change interventions.
Well, to kind of get at the kind of what's out there in terms of this type of intervention, we did a systematic review back in 2013, I believe, so it's been about 2 years, and kind of looked at what was out there and the quality of what was out there in terms of evidence-based research. And we only found a handful of electronic-based, so they weren't even video games. They were just electronic-based interventions. And out of those, we only found 3 that were focused on sexual risk, and none of those were video games. So I don't even have anything really to compare it to. I think it's probably the first that I know of that is a video game, an interactive video game that focuses on HIV prevention and sexual risk reduction. Storytelling, I think it kind of goes hand in hand with video games often. That's why I think it was just kind of it naturally lend itself well to this intervention. I think what we're finding too is we're using the game. We're not using it in the traditional way when we're piloting the game in groups, large groups, in some of these cities here in the U.S. We're actually kind of using the stories as a way to kind of spark discussions. So we'll pull out the video game and we'll bring up some of the story elements, some of the story chapters, and we'll use those as a way to get discussion started. And what had happened was the peer health exchange, the group before would just give scenarios. They go, so pretend that your friend, is trying to get you to sell grandma's pills at school. What do you do? Well, we have an actual video, like a part of the video game that we can actually show, and kids can kind of watch it and get there's characters, and it's very visual. So the idea of storytelling, I think, has kind of always been there, but maybe just in a different way.
Okay, great. Kim, I'll ask you another question. So you mentioned that you're looking at evidence on how the children who are involved in experiencing this game are reporting behavior change over time, and that's sort of how you're evaluating how effective the intervention is. I guess one question I have is, do you get the sense that children are telling you what they expect you to hear because it's sort of a test situation, because they know that they're being exposed to this? And I guess what I'm leading to is, do you have any evidence on whether or not sexual risk behaviors are changing in the New Haven community, sort of using more population-based data? Or is that something that you imagine will happen eventually and that you'd be able to measure that change? Or do you see this as something that really is going to be useful for the participants who are engaged directly in the, I won't call it a focus group, but in the experience of playing the game?
Well, I guess, no, we haven't really looked at the population data for New Haven, but given that we have a control arm of the intervention, regardless of if there are changes, and we'll be able to account for that because we have the control group. What was your other question?
Oh, no, I guess I was really curious about whether you would, really about the population data. I don't even know if they would have, if there's a good sort of sentinel survey done on sexual health behavior in the region. But I just thought it would be interesting if you would, over time be able to see that shift in the population as more and more kids in the community are playing that game. Because of course, I wouldn't just expect the impact to be on the kids who play the game itself. They would probably diffuse that through their social networks as well.
Yeah, that would be wonderful. Yeah, I don't know. I'm not sure. That would be very interesting.
Okay. Another question I have for both of you is, actually, I have a question for the audience first. If anyone in the audience knows about other models of digital storytelling for behavior change, or more in line with Bruce's app, where it might not be about smoking cessation, but an app for behavior change, and you want to share that with us, please enter it in the chat box. It would be great to learn about a range of other examples. But I actually wanted to ask Bruce and Kim, both of you have been immersed, it sounds like, in developing these technological approaches. And I wonder, are there other examples of apps or games that you've learned about that really impress you? Because I think it would be really interesting to hear from your perspective what you sort of see as being other models that we should be looking into, or other examples. It's kind of like asking a musician, what's your favorite album? But what do you think are some other great models out there?
Well, for us, there was Remission. Hope Lab did they've done a Remission 1 and Remission 2, which is adherence to cancer medication for young kids. And it's a behavior change game, and it's an amazing game, 1, and 2, it's effective, so it's been shown to influence behaviors, and it's also a very well done research study. So that one has been kind of a great model for us in terms of how that was conducted. There's also an intervention called It's Your Game, that it does use some electronic-based features like videos. So it's not a video game, but it's also another very well done intervention and study that we really, really turn to in terms of how, the way that it was done, and we modeled after that. So.
Oh, great, thanks.
Hi, Ketan. There's been a number of things that we've seen that have impressed us. When we did our comparative scan at the time, that was back in 2012, we did find that the one app that seemed to do better than others was an app by the Livestrong group, where they had developed, I think they have a series of apps for behavior change, and we looked at the one regarding smoking. We thought that was a fairly good app. I don't know what the status of that is any longer, given what's happened with Livestrong. The other things that we looked at were the work that was coming out of the U of T and the Health Sciences Centre in Toronto. There was 2 examples that struck us very interesting and gave us ideas on how an app should perform. There was a blood glucose monitoring app that was developed by the U of T folks on a totally different topic than smoking cessation, but how it worked and the user interface was very interesting. And there was a researcher who I apologize, I've forgotten the name of, who has been working with kids with cancer at the Hospital for Sick Kids. And she has developed a very interesting app, game-based. It employed actors from the cop or fire cop show that takes place in Toronto. I forget the name of it, but it was really well developed and put together. And she had shown some interesting impacts with going on in the hospital setting, helping kids manage their pain who had cancer. So that also impressed us. And the last one that I just recently learned about is something that's being worked on at CAMH. And it's another smartphone app, but it's intended to work with the client and the health professional, and it's called My Change Plan. So CAMH is taking a different approach. they're developing something that can be used both by the health professional that is counseling the individual about addictions, as well as the client. And they're working on that right now.
Oh, interesting. Okay. Well, I do want to move on to audience questions very shortly. I just have one more question for both of you. So a lot of us in the audience are people who are trying to do health promotion who aren't necessarily averse to maybe even developing our own interventions one day. And so my question for both of you is, what was the process of working on or sort of becoming somebody who works on addressing behavior change using technology? What has that process been like for you personally? What were your backgrounds in terms of your education? Is this something that you've been working towards your whole life, or is this something that you've sort of adapted to the field of technological interventions? And maybe if you could just give us some insight on how you sort of made it work. What sort of helped you become somebody who works in this field? Because this is a field that really didn't exist 15 years ago, say.
I think I kind of just fell into it. I think I was just very, very lucky in terms of I got my PhD in health behavior, so I was really focused on health behavior change. And I'm also a gamer. I've grown up loving to play games, all kinds of games. And so when the opportunity came up, there was a position here at Yale, and I was like, yeah, I'll just apply and see. And I got it, and it just kind of everything kind of fell together. It's one of those things I don't think, kind of putting the best of two worlds together for me. So just it kind of is that idea of, when you love what you do, you never work a day in your life kind of feeling. I love what I do. I love games. I love what games can do in terms of influencing people and behaviors, and games are amazing. They're just an amazing way to reach people. Kind of always felt that even before I kind of thought of it as a career. So to be able to put the two worlds together has kind of been a dream. Yeah, I feel like I have the best job in the world sometimes. So.
Yeah, you're really lucky, Kim. That sounds great.
Okay, Sam, for me, I'm older. I've been working in the population health field for quite some time at different levels of governments and at the university. And what drew us to the smartphone technology and app development was observation, just working with students here at the university and seeing how 5 years ago, even 5 years ago, but even more so now, how people are basically staring down at their smartphones as they're walking across campus. And so trying to think about how we could take advantage of that technology to help support behavior change. Observation and actually inspiration from my own family. My own daughter, who's older now and is big into gaming and use of mobile technology, she's the one who advised me that we should create an app to help people quit smoking and some other behaviors that she thought was a problem with amongst her peers as well. So yeah, observation, and I have to credit my daughter for having inspired me to do something about it with mobile technology. Otherwise, we'd be just putting out our standard paper-based self-help guides.
Yeah. Okay, great. Well, thank you so much for those personal reflections. I'm going to ask Lindsay Kawamoto now to come online and see what the questions are from the audience.
Thank you, Caden. I think I'll start with one of the first questions for both our presenters. You touched upon your target populations, but could you quickly reiterate what those were, and if you think your technology is only applicable to this group, or would it be transferable to other age groups as well?
Would you like me to go first, Lindsay?
Sure, sorry. Yes, go ahead, Bruce.
Yeah, our game plan to start was to reach 19 to 29-year-olds from the standpoint of had the highest smoking prevalence in Canada, so we thought that was a good place to start. And the fact that when we looked at the data that we were getting secondhand, some of the heaviest users of mobile technology fit into that age group. But that being said, when we look at the actual data that we're collecting with regards to use of the app, there are people over 60 who are downloading the app and are making use of it. And there are people younger than 19 who are downloading the app and making use of it. So it does appeal to a broader age range. I think anybody who is wanting to do something about their smoking and wants to take advantage of something like a smartphone app to see if it can help them, it's suitable.
Great, thank you. And Kim?
Yeah, so what we found is with the content of our game that the game was developed for young teens 11 to 14, but we've found that older kids, especially like right now we're piloting in high schools, so 14 to 15-year-olds are still getting quite a lot out of the game as well. And then we're also in the process of taking the game, the actual framework of the game, and changing it to focus on other health behaviors. We have one that we're working on now around smoking prevention, and another one around heart disease, cancer prevention, and marijuana use. So the game itself is very moldable in terms of what we can do with it, and who we can target, which has been really, really cool because we can use the game for a lot of different reasons.
Great. I think Sabina had a follow-up question about your target population in terms of was there a high rate of HIV among teens in your target group, or why did you choose to focus on HIV reduction as your key goal?
Well, so we decided to focus on at-risk minority youth because they are a population that is at high risk for health disparities. Young Black teens and ethnic minorities, Hispanic minority youth they're at a higher risk for HIV and STI infection, and they're also generally at higher risk for engaging in at-risk behaviors. So because of that, that was our target population.
Great, thank you. Moving on to the next question. So what were some of the most successful ways that you engaged users? And one of our participants specifically wanted to know about people who are not early adopters of technology. And then maybe Bruce, you can start with that.
Some of the most successful ways that we engaged users, and talking about early adopters versus late adopters. Yeah, the Rogers innovation theory, or a framework like that, we did not apply. So the idea of trying to convince people who may not be wanting to use smartphone technology to get them to use it is not something that we focused on. And I guess the reason for that was because the majority of the population that we were trying to reach out to seemed to be also already making use of the smartphone technology. So in terms of the innovation curve from Rogers innovation theory, there doesn't seem to be too many late adopters left within that population group. So that, for me, is why we didn't look at it from an early adopter versus late adopter perspective. That doesn't mean it's not applicable to other population groups. We had our discussion a little earlier about low-income groups that may not be able to afford smartphone technology. How could you reach out to them? But no, we did not approach the recruitment or reaching out to individuals from an early adopter, late adopter sort of perspective.
Okay, great. And Kim, did you have the same sort of experience as a late adopter, early adopter?
Well, it wasn't really an issue with us because we were working with kids, and it was actually more the adults that had the pushback. Like, how are kids going to know how to maneuver this and manage this? And it's actually quite funny because if you hand an iPad even to a 6-year-old or a 3-year-old, it's amazing how fast they pick it up and know what to do. So it was easier for the kids to actually pick up the game and play it as opposed to when we were trying to demo it to our older audiences, or even like principals and teachers. But kids had no problem and that's what's been kind of the selling point. Kids just pick it up and figure it out pretty fast. They don't have they're not nervous about it like older adults seem to be. They just kind of jump in.
Great. Okay, perfect. And we just have one last question. So again, if anyone has any other questions, please feel free to type it in the chat box. I guess the last question being, have you had any experience or any advice on how to measure your results with limited resources, for example, a limited budget or limited technology?
In terms of assessment, gathering assessment data, is that was the question?
Yeah, gathering assessment data or any part of the RCT even.
Well, for us, we did everything. All of our assessment data was collected actually with in-person paper. One, because we wanted to make sure that the kids understood the questions we were asking, and a lot of them were questions that maybe they'd never been faced with before, you know, like, have you ever had oral sex? Well, what is oral sex? You know, and trying to make sure they understand what that means. So we did face-to-face interviews with them, especially, you know, to ensure that we had the appropriate reading level. So, you know, I know everything's kind of moving more towards computer-based assessments, but the old school, you know, paper pencil assessments has worked well for us for the past 2 years with this project. And, you know, we continue to do it with our younger kids as well.
Okay, great. And Bruce, did you have any experience or any advice on how to measure results with limited resources?
Yeah, this is not the first project where we've gone totally online. We did an evaluation for the Canadian Cancer Society of their Break It Off campaign, and we learned a lot about online recruitment and conducting online surveys. And it's turned out to be much less expensive for us to do things online and recruit people online using Facebook ads, for example, which the cost per recruit ends up being about $8 a person. So it's I have a colleague in the office with me right now who knows all these details. Yeah, so that's how we've gone through our process in terms of you know, what can work for others who don't have huge budgets. We've been able to save a lot of money going from paper-based to doing everything online, and it's worked very well for us.
Great, thanks. I know it's very helpful for us who work in local health units, and we don't always have a big budget. So again, I'll just turn it out to the audience again. If there's any other questions, please feel free to type it in the box. And if not, I'll just turn it back to you, Caton.
Okay, great. Thank you. So I think it's time to wrap up then, because I don't see any more questions coming through the chat box. I want to thank our presenters, Kim and Bruce, for sharing their recent work and for being open to a bit of a discussion about that work. It was really educational for myself. This is such an emerging field of health promotion. And, you know, I myself, like you, Kim, I've spent my whole life around video games, basically, and never really seen the potential or experienced the potential of it to actually merge into my area of work in terms of health promotion. Of course, much more recently, it's becoming much more, the market's being saturated with apps that you can get on Google Play and on iTunes to do sort of self-help or sort of personal approaches to changing health behaviors. And it's really heartening to see a couple of great projects like yours that are taking a much more theoretical approach to designing the apps and going through the process of testing them. And it certainly is a sign of where the field is going towards in the future. So I think we were really lucky to have the two of you share your experiences with us. Thank you very much, and I want to also mention to the audience, remind them again that we're going to have a second webinar in this series where next week on Wednesday at the same time from 12 to 2, we're going to learn about 2 examples of how technology can be used to facilitate advocacy for health promotion. And actually, both of the examples are in the field of food security. So if you know of anyone else, a colleague who works in health promotion who's focused on food security, it's going to be a really interesting session. We're going to learn about how you can affect the outcomes of local elections using technological approaches, and how you can use technology to strengthen social networks for food security as well. So if you haven't registered for that as yet and you're interested, the address is there at the bottom of the slide, or you can go to the OPHA website, and we hope to see you next week as well. So thank you to everyone, most of all our presenters, and hope you have a great day.
Thanks very much.